Hi everyone, it's Schematic Med, and today we're going to talk about diabetes mellitus therapy. All patients with diabetes mellitus should receive education on diet, exercise, blood glucose monitoring, and complication management. Treatment differs based on the type of diabetes and glycemic control. In type 1 diabetes mellitus, we use insulin replacement. In type 2 diabetes mellitus, we use oral agents, non-insulin injectables, and insulin replacement. Weight loss particularly helpful in lowering blood glucose. And gestational diabetes mellitus, we use insulin replacement if nutrition therapy and exercise alone fail. Let's start from insulin preparations. The classification of these drugs are based on their length of action. We have rapid-acting, short-acting, intermediate-acting, long-acting, and very long-acting insulins. The mechanism of action is following. Insulin preparation binds insulin receptor, which has tyrosine kinase activity. In liver, it increases glucose storage as glycogen. In muscles, it increases glycogen and protein synthesis. In fat, it increases triglyceride storage, and in cell membrane increases potassium uptake. We will remember all adverse effects of drugs that we use in diabetes mellitus with the help of pictures. I think that is more productive than just writing them down. Adverse effects of insulin preparations are hypoglycemia. I think it is very logical because insulin preparations will act as insulin. Hypersensitivity reactions, which are very rare, and lipodystrophy, which occurs especially in the site where we inject the insulin preparations. Patients who use insulin preparation gain weight. Now let's talk about oral agents that we use. We classify these drugs by their mechanism of action. First group are drugs that increase insulin sensitivity. Drugs are Metformin and Pioglitazone. Metformin inhibits mitochondrial glycerol 3-phosphate dehydrogenase, MGPD, which subsequently inhibits hepatic gluconeogenesis and the action of glucagon. This drug increases glycolysis, and because it increases insulin sensitivity, it increases peripheral glucose uptake. The adverse effects are GI upset and lactic acidosis, and that's why we should be very cautious in renal insufficiency. Sometimes it can cause vitamin B12 deficiency, and while using this drug, patient lost weight, which is often desired. Next drug in this group is Pioglitazone, which activates PPAR-gamma, a nuclear receptor, which increases insulin sensitivity and levels of adiponectin. This leads to regulation of glucose metabolism and fatty acid storage. Pioglitazone's adverse effects are edema, heart failure, high risk of fractures, and this drug has delayed onset of action, approximately several weeks, and patients who use pioglitazone gain weight. Next group is drugs that increase insulin secretion. These drugs are first and second generation sulfonylureas and meglitinides. These drugs close potassium channels in pancreatic beta cell membrane. After that, cell depolarizes and contributes to insulin release via increased calcium influx. Adverse effects are disulfiram-like reaction with first-generation sulfonylureas only, which is rarely used, and hypoglycemia, especially when we have renal insufficiency, and patients who use these drugs gain weight. Next group's mechanism of action is increasing glucose-induced insulin secretion. The group drugs are GLP-1 analogs and DPP-4 inhibitors. GLP-1 analogs decrease glucagon release, decrease gastric emptying, and increase glucose-dependent insulin release. Adverse effects are nausea, vomiting, pancreatitis, and it increases satiety, which is often desired. These adverse effects are very logical because when we decrease gastric emptying, it can cause nausea, vomiting, and increase satiety feeling. These drugs help patients to lose weight, which is often very desirable. And DPP-4 inhibitors, which inhibit the enzyme DPP-4 that deactivates GLP-1 and subsequently decreases glucagon release, decreases gastric emptying, and increases glucose-dependent insulin release. DPP-4 inhibitors can cause respiratory and urinary infections. These drugs are weight neutral, and again, as previous one, it increases satiety because it decreases gastric emptying, which is often desired too. Next drug group, decrease glucose absorption. These drugs are sodium glucose cotransporter 2 inhibitors and α-glucosidase inhibitors. Sodium glucose cotransporter 2 inhibitors block reabsorption of glucose in proximal convoluted tubule. Because it blocks glucose reabsorption, we will have glucosuria, which can lead to UTIs and vulvovaginitis. Because glucose is very osmotic, it can pull water from the body to urine, and it will lead to dehydration with subsequent orthostatic hypertension. Again, we need to be very cautious when we have renal insufficiency and decreased GFR. Sodium glucose cotransporter 2 inhibitors help patients to lose weight. Alpha-glucosidase inhibitors inhibit intestinal brush border alpha-glucosidase, which delays carbohydrate hydrolysis and glucose absorption, which leads to decreased postprandial hyperglycemia. If carbohydrates stay a little longer in intestine, it will lead to GI upset and bloating. And these drugs again are not recommended in renal insufficiency. And the last group is Amylin analogs, which decrease glucagon release and decrease gastric emptying. And subsequently, if we decrease gastric emptying, we will increase satiety feeling, which is often desired, and we can have nausea, vomit. And additionally, this group can cause hypoglycemia. Thank you for your attention. Bye.